Ah, Morning, everyone.
Good morning.
Morning. So we'll give it a little bit more time, maybe 5 minutes, just to allow for more people to join, and then we can start the meeting. Thank you. Good morning, everyone, once again. Apologies for starting the meeting late. I think in the interest of time, we can maybe just get started, and people will find us on the way. So today, as you've seen from the agenda, we basically just have one study, which will be presented. Starters, my name's Saha Mambo. I'm the KT officer at the National Health Research Authority. Sorry about that. My deputy director, Madam Sandra Chilengi, is currently in another meeting, but she will be joining us shortly, and she will give the opening remarks for the study. So as you may be aware, the National Health Research Authority offers this platform for dissemination of COVID-related studies every month. So we advise the research community, those that want to present any COVID-related research findings, to reach out to us through the NHRA email. And we also have the scientific meeting. These are quarterly scientific meetings. So our next scientific meeting is on the 14th of December. So maybe we can just take note of that. And if we have any research findings studies we want to disseminate, we can reach out to NHRA. And all these are outside COVID studies. So without much ado, I would just like to welcome all of us to today's meeting, and I'll ask the presenter to just go right ahead with the presentation. Thank you. And also, let's just type our details in the chat box for registration purpose. The name, designation, and the institution we're coming from. Keston, you can go right ahead with the presentation.
Thank you, and good morning to everyone. May I be given the right to share? Okay. I hope you can see my screen.
We're able to see your screen.
Great. As I've been introduced, I'm Keston Liambai from the University of Zambia. So is it okay if people could mute their mics? Yeah, great. So as I was saying, I'm Liambai Keston from the University of Zambia, to be specific, in the School of Nursing Sciences, Department of Mental Health and Psychiatry. So I'm presenting findings of a study entitled COVID-19 Pandemic through the lenses of nurses and midwives in Zambia, basically exploring depression, anxiety, and stress. So I'm presenting this on behalf of a team which comprises Professor Lonia Mape from Levi Mwana Wasa Medical University, Ms. Esther Chira from Levi Mwana Wasa Medical University, Ms. Mavis Mtonga, also from Levi Mwana Wasa Medical University, Dr. Patricia Katoa Mkwato from UNZA School of Nursing Sciences, who happens to be the dean there, and then Dr. Agatha Lloyd from Lusaka District Health Office. So I just happen to be one of the members of the team, and I've been asked to present this on behalf of the team. I know in cases of questions, some of my colleagues are on this call. They should be able to to respond to some of the comments that might arise. Great. Let's just dive into it. So COVID-19, of course, has been with us now for a very long time now. And we might remember that from the time it started, of course, in China, a lot of issues have happened. It spread quite rapidly, worldwide, and hence the World Health Organization decided to declare it as an international health emergency. Now, following the declaration of it as an emergency, Zambia, just like many other countries, implemented measures to primarily limit human interaction for purposes of curbing the spread of the disease. Among these measures included asking people to work from home, schools being closed, issues of social distancing, and many, many other measures that were put in place. Now, amidst all these measures that were put in place by the government, we do know that health workers, to be specific, in this study, the nurses and midwives continue to provide the care to both positive cases of COVID and even those that were just suspected cases of COVID. So they continue to work amidst all these issues that were going on. Now, with all these things going on, with the health workers, with the nurses and midwives working, this definitely put them at risk of not only contracting the disease, but also to some extent compromising their psychological well-being. And this is also stated in several literature, which tells us really that in times of pandemics, like the COVID-19, and even many other pandemics, we did notice that chances of psychological distress are usually actually on the higher side, as postulated by FEDA 2020 and Zeng 2020. Now, with these nurses and midwives being in the front line trying to contain the COVID-19 outbreak, yes, the chances of them contracting the virus were very, very high, but also the risks, their mental health, the risks, their mental well-being were also very high. Them being at risk of developing psychological distress, them developing issues of anxiety, issues of depression, and also just generally stress have been found to be very high, as some of these scholars have stated. Now, despite all this overwhelming evidence that is available from other parts of the world, there's very actually little information as regards this in Zambia. There's very little, there's actually very scanty information, as there are very few studies that have been done in our settings. So because of this gap that we identified, my team decided to conduct a study to basically assess the levels of depression, anxiety, and also stress being experienced by nurses during the COVID-19 pandemic. Okay, and we targeted primarily two districts. This is Lusaka and Chilanga districts. We primarily targeted this district because I think that's where initially we had higher numbers of COVID-19. So we decided to target these two districts to just see what are the levels of depression, what are the levels of anxiety, and also the stress among the nurses and midwives. This study was cross-section in nature, descriptive, and it had both arms, qualitative and quantitative. Though the main arm of the study was quantitative in nature, but also decided to get some aspects of their coping mechanism. How are they coping with these things? And this was done qualitatively. The setting, like I mentioned earlier on, were two selected districts, okay, Lusaka and Chilanga, and we primarily targeted the health workers, the nurses and midwives who are working in these selected health facilities. Among these health facilities were, of course, the main hospitals, 11 Mwanawasa University Teaching Hospital, the clinics, and also the second level hospitals themselves. Most of these facilities were purposively sampled, or purposively selected these ones. Bear in mind that these are the facilities that we are dealing with most of these clients. In terms of the respondents, we conveniently selected these respondents, those that were found in these facilities at the time of data collection. These are people that we primarily targeted. And these health workers, or these nurses and midwives, were primarily coming from departments such as the outpatient department, the emergency units, the admission wards, and also some COVID centers. Yeah, some COVID treatment centers were also targeted. However, in the process of collecting data, of course, issues of access, because of the tool that we're using, accessing the actual COVID sites proved to be a little bit challenging. So you notice as we go on that there are very few that we actually interviewed who are coming from who are actually working in the COVID centers. Yeah. But most of them were working in these other hospitals who we know to some extent are also coming in contact with these clients, whether confirmed or unconfirmed. The sample size was basically 228, okay, and this was calculated based on the target population. To collect data, we used the DAS, which is the Depression, Anxiety, and Stress Scale 21. That's a tool that we used to collect data. So this tool is a validated tool that has been used globally, and of course, its reliability and validity is quite high. To analyze the data that we collected, SPSS was used, and of course, measures of central tendency and also univariate analysis and chi-square were used. What were the findings from the study? In terms of the demographics, of course, we targeted above 200, but after collecting the data and screening the questionnaires, 187 questionnaires were considered to be completely filled, and those are the ones that we're able to analyze, and that's basically the information that we're giving out. So you notice 187, quite high figure. It's okay, it's quite acceptable, statistically acceptable, considering the target population and the sample size that we had. Majority of the respondents were primarily female, that's approximately 84%. Of course, that's known. Most of the nurses and midwives are nurses, so this is something that we anticipated. A good number of them, 58.3%, were married, and then 50.84% actually had children. In terms of work experience, the mean work experience was 6.63 years. That was the mean work experience for most of the respondents. Then 54% had worked actually for less than 5 years. So these are relatively younger nurses and midwives who are, a good number of them just newly qualified, newly graduated, have been posted to work in these facilities. In terms of the actual findings to do with the DAS, what we did find out is that overall, approximately 22.5% of the nurses that were interviewed, nurses and midwives that were interviewed, actually did report the presence of depression, okay, 22.5%. And of this figure, we do notice that 9.1% had actually severe depression. 9.1, quite high figure, reported severe COVID-related depression. Of the respondents, 52.4% had some COVID-19 related anxiety, with approximately 10.7% of them exhibiting severe anxiety. Now, in terms of stress, we did find out that 24.1% of the respondents had moderate levels of COVID-19 related stress. Also, similarly, we had 9.1% who exhibited severe levels of stress. So these are quite higher figures. Okay, these are quite alarming figures, and you will notice that actually these figures are almost within the findings from other parts of the world. We went further to do some cross tabulations. So on cross tabulation, we did find that, well, there was actually a statistically significant relationship between the ward or the department where one was working from and also issues of COVID-related anxiety. And it was also, with this, it was noted that those that were working primarily in COVID centers, though there were very few, those who were working in COVID centers, most of them had severe levels of anxiety, COVID-related anxiety, followed by those who are working in other settings, such as the outpatient department. And the main issue for that was because most of the people that were coming there, some of them were not diagnosed yet, they are not confirmed cases, but by virtue of them coming to the hospital, that was also a source of anxiety, that was a source of worry. The fact that these are the people who are in the forefront, people that were the first contact of these patients. That's what could have actually contributed to the severe levels of anxiety. Further to that, there was also a significant association between the stress levels and also the ward one was working from, with those that were working in casualty, OPD, and also the COVID treatment centers exhibiting higher levels of psychological distress. In terms of measures that were seen to be very supportive, what we did find out was that issues of those who are seeking help from family and friends, those who are in touch, who had a good relationship with their peers, were noticed to have actually lower levels of both anxiety and depression. Issues also of support from the hospital management proved to be also very supportive in terms of alleviating some of these COVID-related anxiety, depression, and also stress itself. On the other hand, we did notice that those who are relatively younger, the younger health workers, are the ones who had serious COVID-related anxiety and depression, unlike those that were slightly more experienced, those were a little bit on the older side, the levels were slightly less. Yeah. So meaning that the more one worked, yes, the more supportive that proved to be. The more experienced one, the less the anxiety, the less the depression, and so on and so forth. Okay. Now, these are findings, alarming. Of course, they're quite alarming. They're quite higher levels of anxiety, stress, and depression. And this is quite similar to what other scholars did find out. Lain and others, Shah and others, Sigdeo and others, all these found quite alarming levels of COVID-19 related anxiety, stress, and depression. And this is quite similar to what we did find as well. Now, the levels are particularly high among nurses and midwives, especially those who are said to be in the front line. Unlike these others who are working in other wards, for instance, those that are working with wards such as in maternity, those are working in wards such as maybe TB units and things like that. We notice that the levels were slightly quite lower, but those who are directly in the front line, those who are working in the COVID centers, those who are working in outpatient departments, in the screening units, they're the ones that were found to have higher levels. And this is similar to what other scholars also did find in other parts of the world. In terms of the levels of depression, what we notice is that our findings are slightly lower than what other people did find out. Okay? What other parts of the world have found out is that the levels could be slightly higher, as high as 40%, as high as 52% by other scholars. But what we found was slightly lower. And of course, we are attributing this discrepancy maybe due to the methodological limitations. With us, what we did, we used the questionnaire, and this questionnaire we actually physically distributed to the respondents, waited for them as they filled it in, and were able to interview some of those. Okay, but what other scholars did, they did online kind of surveys. So that could have contributed to the discrepancies that we are seeing. but also the tools that we use. For us, we use the DAS, okay, the DAS 21, that's what we use, which we know is something that is quite credible, quite valid, quite reliable, but other people use different screening tools for depression, anxiety, and stress. So these could be some of the issues that would have contributed to the differences, to be specific in terms of depression. The other findings, almost within what other scholars, other parts of the world did find. In terms of conclusion, of course, yes, we have found that the levels of depression, anxiety, and stress are on the higher side among the health workers here in Zambia, which is similar to what others did find out. So we do recommend that in order for us to be able to mitigate some of these risk factors, we need to consider responsive interventions, such as probably training the health workers in issues of psychological flexibility, okay, that will to some extent enhance their mental health resilience to be able to deal with the adversities that could come in with COVID-19. Especially now that as we are thinking of the fourth wave that might be coming, so we need to start thinking of measures to enhance the psychological flexibility of the health workers. Other issues that we do recommend is considering internet-based treatments. These internet-based treatments are available, and other parts of the world are actually using these internet-based treatments. For instance, issues of ACT is one of the common psychological or internet-based treatments. Though here in our settings, we're not using that. So we could consider using some of these approaches to basically increase the resilience, and be able to offer our nurses and midwives access to mental health care. Bear in mind the stigma and discrimination that is associated with seeking mental health services in our settings. We know there are a lot of strategies that the ministry has put in place. Strategies such as probably using organizations such as Lifeline, where those health workers that have psychological problems could be able to cope. But even with all these strategies that have been put in place, we do see that the numbers of people actually, of health workers that are seeking these services are quite low, okay? The numbers of health workers that are calling Lifeline to seek mental health support, they are very, very low. Okay, there are all these strategies, but maybe we might have to consider internet-based treatments. These might prove to be very, very helpful. So it is hoped that some of these interventions that we recommend could help alleviate the psychological trauma that some of our nurses and midwives may be going through during this pandemic. Okay, in a nutshell, that's what I had to present. So those are some of our references. So at this point, I'm going to take questions and contributions. Thank you very much.
Thank you so much, Kirsten, for that presentation and for being very clear about your findings and everything. So we have comments in the chat box. So I would advise for those that have questions or comments to either put them in the chat box or they can speak if they wish to. There's a comment from Wupe. I don't know if she's still logged in. Probably she can just ask the question, or maybe we read the question. Wupe?
Yes, I can ask the question. So thank you, Kirsten, for a very informative and timely study. And so my first question is with regards to the numbers. So you mentioned that your sample size from the actual nurses that were working in COVID centers were very few. Are you able to give us the actual few? What does the few mean? How many of those that you interviewed were from the COVID centers? And especially that you were focusing on looking at your findings, you were looking at anxiety related to COVID. So if they were not working in COVID centers, how was it affecting them working outside COVID centers by getting stressed? And my second question was with regards to your cited studies. What were they undertaken? Was it a similar location to a lower middle income countries, or you're looking at high income countries in relation to COVID management? Because that's totally different, speaking from experience. Thank you.
Great. Thank you, Rupe, for those questions. Probably I'll start with the last one in terms of the cited studies. We actually cited quite a number of studies. Some of them are studies that were conducted in China, some of them in Sweden, some of them in Australia, some of them in Tanzania, some of them in Kenya. But now, in terms of the findings, what we do notice is that, of course, in terms of the levels of the psychological problems, depression, anxiety, and stress, they are almost the same. They are almost the same. There are slight differences in terms of the actual numbers, in terms of the actual percentages, but what we found is almost comparable to what other scholars, whether in a developed country, whether in a country like ours, the levels are almost comparable actually. I hope I've taken that, I've answered that one. The next one, the other part of the question was what I meant by the few in terms of the numbers, those that are coming from the COVID centers. Yeah, from the COVID centers, the actual number was about 19 that came from who were actually working in the COVID treatment centers. Those were actually working in the COVID-19. From the 180, from the over 180 respondents, only 19 were working from the COVID treatment centers. But now, if you see the way we selected our sites, most of these sites, in one or another, were dealing with clients that had COVID, either diagnosed or undiagnosed. Okay, the COVID treatment center was just there to treat those that had actually severe COVID-related issues. They had severe problems, but these are patients that would have passed through, for instance, Challenge first level or material first level. They could have passed through these settings already. They could have been screened in OPD. So there was a lot of, actually what we noticed, there was a lot of anxiety among those that are working in those facilities, especially by virtue of it not yet being diagnosed, not yet being confirmed. When you know that something is confirmed already, you already, somehow to some extent, you know how to protect yourself, you know how to take care of yourself. You and me will know that in the COVID centers themselves, maybe as much as the levels were quite high, but in those centers, there were issues of protective equipment. People were using the masks, the PEPs were readily available in those centers, unlike in facilities such as Kanyama. So probably the anxiety could have actually been high. The anxiety is actually higher in those areas. And that's what we did find out. I hope I've responded to your question. In case I'm not very clear, yeah, my colleagues are also on this call. They should be able to respond in case of anything. Madam Esther Chirwa, in case you want to add, please just unmute yourself and go ahead. Yeah. Thank you.
Rupe, are you okay with the responses?
Yes, I am very, very okay with the responses. Yeah, thank you, Keston.
Thank you.
Yes, a comment from Professor Bilbeck. She says, I'll just read the comment. It is understandable, but unfortunate that you could not sample from very much from the COVID centers. Did you capture enough nurses and midwives from the COVID center to do a subgroup analysis and see if they differ from the primary sample in terms of depression, anxiety, or stress? I don't know if you got that, Keston.
No, I didn't get that, but I hope I've got what you are saying.
Yes.
Did we get enough numbers from the COVID center? Initially, we expected to get quite higher numbers from the COVID centers. That's what we had anticipated, actually. But I think we had all these limitations. We had all these challenges. Accessing those sites were kind of a challenge from the way to go. Maybe because of the methodologies that we're using, the tool that we're using, okay? So now we're actually thinking that maybe we could have considered other ways of collecting this data from this setup. In other follow-up studies, I think these are some of the things that we can consider, okay? Getting a higher number from these, especially COVID treatment centers, okay? And maybe consider online kind of tools. We just say, get a list of the health workers that are working in those facilities and we email them the tools. However, in our settings, you and me know that there are a lot of challenges with online questionnaires. The response rate is usually very, very poor. That's why we preferred to administer this questionnaire, wait for the people to fill in these questionnaires. But I think that's something that we can consider for upcoming studies. I hope I've responded to what you are asking.
Yes, you have. Yeah. So there is a follow-up to say, did you do any subgroup analysis for the nurses and midwives that were actually specifically in the COVID centers?
No, I think that was not done because the numbers were quite low. Numbers from the center itself, the COVID centers, were quite low. Because of the lower numbers, we thought it would not make sense statistically to do that. Thank you.
Any other reactions, comments?
Question again. So Kirsten, I was just thinking, did you also look at the contributing factors to that? Was it just COVID related, or were there any other issues that were picked, or you were not able to actually determine the cause of that anxiety? Was it just the issue of patients coming in whom they are not sure if they are COVID positive or not, and that was contributing to their anxieties? Or did you look at other issues as well? Because considering that, especially that the majority were from non-COVID centers, what did you confound? Were they in confounding factors to that depression, or the anxiety levels, or was it just so basic looking at COVID management? Thank you.
Yeah. Of course, confounders are always there, and we tried to rule out as many confounders as possible. But based on the methodology that we used, we strongly feel actually most of the anxieties, most of the depression is COVID related. Remember, this study was twofold. We had the qualitative aspect and the quantitative aspect. And from the in-depth interviews, that we did, we're able to establish that actually most of the anxieties could be COVID related. But now, one thing that we might have to do for follow-up studies could be, one, we will need to do some baseline survey first, establish what are the normal levels, okay? What are the normal levels? And I think that's what some people, some scholars have done that. For instance, there's one study in Sweden. What they did was prior to COVID, they already knew what the levels of anxiety were, what the levels of stress were, what the levels of depression were among this cohort. They already had that information. Such that later on, with the coming in of COVID, they were able to compare the two to say, okay, yes, actually, it's COVID that has actually contributed to this, because they already had that information at hand. But with us, that information is not there. Okay, because you and me know that there are very few studies that have been done in the area of mental health. There's scanty information in the area of mental health. So you and me have quite a lot to do. And I think that's one of the things that we need to do, for us to be very sure that, yes, this is actually primarily due to COVID. We need to have such kind of information at hand, which we did not have in our setting. Yeah. Madam Esther, would you want to add something to that? Or any other members of the team?
Actually, I just wanted to concur with you that if there was a baseline data to know that this was the levels of COVID, the levels of anxiety in nurses, then it will be easier for us just to say COVID is the one which has increased the levels to where they are today. But since we didn't have, we are looking at the information which was given to us, and it pointed to COVID-19 as the reason why they were they had high levels of depression. And one factor is because non-availability of the PPEs, uncertainty of the tests results in some areas, and also like in health centers where you are nurses where they are the first contact with patients and you don't even know whether this patient is positive or not. So those are some of the reasons. However, there were some like stigma, which we can talk about, but mainly it was the levels of anxiety, depression were surrounded around COVID-19.
Just a follow-up question with regards to that. So just listening to what you're presenting, to say there were those things like lack of PPE and a lot of other things. So now my follow-up question is with regards to preparations for the fourth wave that Keston spoke about. So now that you discovered all of that, and I've seen that the director nursing and midwifery services was there, what things did you move for, like ahead in planning with regards to provision of PPE, and even like how best you can manage that? Because I can tell you here in Australia, like from the time that COVID started, you can't just walk to the hospital and say, I'm sick. You don't do that. So you only those people that, if you happen to go to the hospital, you need to show your results. So you need to go through a center. There were pop-up centers that were established. And so you can't just go to the hospital because of that. You can't just wake up and say, no, I'm not feeling too well, so I have to go to the hospital without having a COVID swab and result. So in planning for probably the future, because you were a very good team there, I've already seen with the director of nursing services, it is very important to start planning using what you have. And so one of the interventions that you mentioned, Keston, you didn't talk about having a psychologist or having people to talk to the nurses and midwives for the debriefing, because if people are stressed at work and you expect them to go and use an app to find solutions, I think it is high time we started thinking about having a psychologist, or I don't know if we have many psychologists, but somebody to talk to at work, like even like providing a specific service with regards to debriefing, because if they are stressed at work and we expect them to find their own ways of dealing with that stress, I think it is not really good. We need to move a step ahead. We need to have people that we can talk to just there at work to say, I'm so stressed, please help me. I'm so scared, and all of those things. Yeah, so just looking at how best we can move on, especially that we're anticipating the fourth wave in Zambia. Your study is very, very important because these are frontline workers. And so how best will this study help in structuring COVID management among nurses and midwives? You've already seen there's depression. So what next? Making it better for the nurses and not just talking about the study without implementing some few things that can be done. So yeah, that's just my thoughts with regards to what you've said, Madam Esther.
Thank you so much.
Thank you, Wupe,
for that.
Oh, please.
No, you can go ahead. You can go ahead, Kirsten. Sorry, I was just thanking Wupe for that reaction too.
Oh, yeah, indeed, very good reaction from Wupe. Maybe before I comment on what Wupe had said, Mike, your hand is up. Do you want to comment first before I can come in?
Thank you very much for the opportunity. Yeah, what I wanted to say is, why does depression come? I think very often it's because there is a stigma associated. We saw it with HIV. If you go back to HIV, if you go back to even conditions that preceded HIV, there's so much stigmatization. And so my assumption is that with the fourth wave coming, and now we know there is vaccination, and many of the cases which we are hearing are actually attributable to non-vaccination. So to an extent, it's becoming a disease of the unvaccinated. But we have also seen it with HIV. I think part of the reason there is so much opening up and less depression is that there is much more openness, and there is also treatment for prevention, even for those that are living with the condition. And so maybe we need to embed that concept of trying to demystify, destigmatize, so that we lessen the potential for depression. When there is less stigmatization and people are much more open and they can consult and they can talk about it, and hopefully we then can make an impact in terms of depression. Thank you. I just thought it's a very good presentation, and make an observation in terms of how we have seen some of these conditions historically, and that intersection with that historical phase. I thank you.
Thank you so much, Dr. Mbizo. Kirsten, you can react to the comments.
Yeah, thank you. Indeed, we appreciate all the comments that are coming. And of course, this study was timely, and we feel it's an important study. It should be able to inform policy. That's what we feel. That's what we believe in. So if you look at actually the composition of the team itself, it was quite diverse. We had people from all over, not just academia, but also the director, nursing services, whom you alluded to, Wupe. And we feel some of this information should be able to be used to direct policy. Now, we know already the Ministry of Health has started aspects of ensuring that health workers have access to psychological support. This support is one of the ways is coming up with the Lifeline. There's Lifeline which offers psychological support. There are counselors out there, and the numbers have been circulated to all the health workers, that those that feel some distress, psychological issues, they should be able to call Lifelines, a toll-free number. They'll be able to receive that much needed support. However, like I did mention earlier on, even with that intervention being there are very few numbers. Okay, a colleague from Lifeline, okay, I sit on the team of Lifeline as well. A colleague there was telling me the numbers are still very, very low. Even with these results, these alarming figures that we are seeing, the numbers of health workers that are seeking help are very, very low. So now we are thinking outside the box. What else can we do? Yes, we can think of ensuring that psychologists are available. Okay, psychologists are available. They can debrief and do all that. Yes, that's another good one. But also, we know that accessing these psychologists is a challenge in our settings. There are very few psychologists in our settings. Clinical psychologists. Not every health facility has a clinical psychologist. Even just here in Lusaka, the numbers are countable. We can count them. So yes, that is one thing that we can do. We can consider doing that. But we're also thinking of other strategies that we can use to ensure that our health workers have access to the mental health support that they need. And one of the strategies that we are recommending is the issue of telemedicine, issues of harnessing the online or internet psychological support. That, to some extent, could help. Because you and me know very well that with COVID, there are issues of social distancing. So even counseling now, even psychotherapies that are being offered now, we are heading towards the psychological aspect. We are heading towards the online kind of therapies. People are using now phone kind of therapies, because it's difficult to sit in the same room with the psychologists these days. There are very few psychologists. And also because of the chances, risks of infections and things like that. So we are thinking of innovative ways of offering psychological support to our patients. So on top of the already existing traditional ways of offering psychological support, we are thinking of all these other ways, these other innovative ways. And among them is psychological flexibility through online kind of support. I hope I've responded to that, but of course we appreciate your comment, and we're hoping some of these findings will be able to definitely help us prepare better for the fourth wave that is coming. Thank you.
Thank you so much, Keston. And indeed, we hope these strategies will definitely be submitted to the Ministry of Health for policy recommendation and strategies that will actually better the service delivery of the midwives and the nurses, especially those in the front line, in the COVID centers. Any further reactions, concerns before we close? Any reactions? Okay, I don't see any hands. So thank you so much, Keston, for that presentations, and thanks everyone for the positive feedback. I hope Keston and team have taken into consideration all the comments that have come from everyone, and these will be onward presented to the higher offices. At this point in time, I would just like to remind us all that for those that have any COVID-related studies and they wish to present, please reach out to us before the mid-month of every month, so that we can then add you to the schedule of presenters for that particular month. The deputy director, unfortunately, is unable to join. The meeting has taken longer than anticipated, and so we will close our meeting at this point. And I just would like to thank everyone for their participation. Thank you, and have a lovely day.
Thank you.
Thank you. Well done, Mr. Keston.